Hello, everyone. Good morning, good afternoon, good evening, whatever time it is on your end that you have chosen to listen in. I want to take this opportunity to welcome you to today's lesson, in which we shall be discussing a very important topic in our setting, that is acute rheumatic fever. Acute rheumatic fever is important in our setting because, firstly, it is one of the commonest causes of acquired cardiac diseases in children. It is also the forerunner of rheumatic heart disease. Rheumatic heart disease greatly and negatively affects the quality of life of any patient, and its consequences can be quite debilitating. Also, acute rheumatic fever is a condition that can be prevented because, as we shall see, it comes as a delayed sequelae of something that we can prevent or we can treat effectively and therefore prevent its occurrence. So I want to welcome you on board. My name is Violet Aswa Akek. I am a lecturer of pediatrics in the Department of Clinical Medicine at the Kenya Medical Training College. This lecture is primarily designed and prepared for clinical medicine pediatric students, so feel free to use it as part of your learning process, or if you're a student of pediatrics, or just use it for your own revision. I know for those of you who are audio students, it will come in handy. So feel free to subscribe, feel free to subscribe so that any other time we post another lesson whose topic may be of interest to you, then you can easily know and tune in. So once again, I want to say welcome. Just a little background into acute rheumatic fever. Somebody may ask you, what is acute rheumatic fever? In general terms, acute rheumatic fever can be defined as a multisystemic or a multisystem inflammatory disease, which is non-suppurative in nature. Multisystem because it affects more than one system. Commonly, it affects the joints, it affects the heart, it affects the central nervous system, it affects the skin, and it also affects the subcutaneous tissue. It is non-suppurative in nature, which means all the other signs of inflammation will be present in the organ that is affected, but there will be no pus. And of importance for you to remember is that it occurs as a delayed sequelae of group A streptococcus pharyngitis. That is to say that if acute streptococcal pharyngitis can be managed well, in a timely manner, effectively, then we can by a great extent reduce the prevalence of acute rheumatic fever and by extension that of rheumatic heart disease in our setting. The onus are on us as clinicians to make sure that we pick these primary infections early enough and we treat them promptly accordingly so that we can be able to improve the quality of the children that we are serving. The question that somebody may ask and we keeps lingering in our minds is that what is the evidence that a throat infection can have a connection to so many other organs and systems away from itself, yet throat infection is localized? So we are going to look at what evidence exists to support this link between the streptococcal upper respiratory tract infection and the development of rheumatic fever, which is a multisystemic inflammatory disease. Number one, we consider history. Studies have shown that of all the children that end up or present with acute rheumatic fever, 2/3 of them will have a positive history of an upper respiratory tract infection at least 2 to 3 weeks before the presentation of acute rheumatic fever. That is link number one. Link number two, the coinciding peak incidences. It has also been shown that the peak incidence for age and season, that is for acute rheumatic fever, is very closely similar to that of group A streptococcal throat infections. What is the link number three? Serology. It has been found that of the patients who present with acute rheumatic fever, almost all of them and almost always they will have high antibody titers against the group A streptococcal organism. Also, it has been found that of those children who end up developing acute rheumatic fever, their antibody titers against the streptococcal organism are actually higher than in those who suffer the pharyngeal infection without developing the acute rheumatic fever. So that provides a very strong link. Still looking at the links. Number 4 is the conjoining outbreaks. It has also been shown that occurrences of group A streptococcal pharyngitis in closed communities, and the best example we can give here is places like child care centers, boarding schools, where we have these school age-going children, where we have had outbreaks of streptococcal throat infections. In those places also, shortly after, there have also been consequential outbreaks of acute rheumatic fever. That is a very strong link. Link number 5 is the treatment, observations in treatments and prophylaxis. It's been found that antibacterial therapy that effectively eliminates the group A streptococcal bacteria from the pharynx also prevents initial episodes of acute rheumatic fever. That is not all. It has also been shown that those children who receive prophylaxis for acute streptococcal pharyngitis, and therefore they do not get recurrences, also do not end up with the recurrences of acute rheumatic fever. That is our link number 5. So we can see we have 5 links that can be used to link the throat infection and the faraway multisystemic inflammation. Okay? So we'll take some time and look at the pathogenesis. And the big question again that we ask is this: what is the pathogenic link between a group A streptococcal URTI and an attack of acute rheumatic fever, which is mainly characterized by organ and tissue involvement far away from it? So far, in our previous slides, we've already seen there is a link between the two conditions. We've looked at the throat infections, we've looked at serology, we've looked at the incidences, peak incidences in age and season. We've looked at the connection between the outbreaks of throat infections and acute rheumatic fever. And we also looked at the prophylaxis and the treatment that is used in the throat infections and how it relates to also preventing the occurrences of acute rheumatic fever and its recurrence. Then the question now we want to answer and look at is, what is that link? The link is there. But what is it that makes that link exist? So we have several theories. We have theories that have been postulated or brought forth, and there are 2. Many of them have been put forth, but only 2 are considered seriously. Number 1 is the cytotoxicity theory, and the number 2 theory is the immunologic theory. So the cytotoxicity theory suggests that a group A streptococcal toxin may be involved in the pathogenesis of acute rheumatic fever and subsequently rheumatic heart disease. That is to say that the toxins that are produced by the group A streptococcus have direct toxic effects on the tissues that are affected, on the connective tissues, on the heart muscle, on the nervous tissue, on the skin. Okay? So a group A streptococcus produce several enzymes that are cytotoxic to mammalian cardiac cells. This has been shown to be the case in vitro. And an example is given of streptolysin O, which has a direct cytotoxic effect on the heart muscle. This has been demonstrated in tissue cultures. So that is the cytotoxic theory, that there are those toxins or enzymes that are produced by the group A streptococcus, and these enzymes have a direct cytotoxic effect on the various tissues and cells that are affected and eventually lead to the development of acute rheumatic fever. However, this theory shortfall of one thing. It fails to explain why there should be a long latent period of 2 to 3 weeks between the episode of the throat infection and the development of acute rheumatic fever. That is the weakness of this particular hypothesis. Hypothesis number 2 was the immunologic theory. And the immunologic theory suggests that an immune-mediated pathogenesis for acute rheumatic fever exists. That is to say that what has been observed is that antigenic determinants are shared between certain components of the group A streptococcus and tissues within the human body. What that consequently leads to is this, that when there is a close resemblance between the components of the streptococcus and cells and tissues in the human body, it means that when the immune system is triggered or it is responding to the infection, antibodies will be produced. When these antibodies are produced, they are supposed to be specific to the streptococcus. However, because of the close resemblance between the streptococcal antigenic material and the human tissue, then the antibodies end up destroying both the organism and also the human tissue. And that is the immunologic theory. That means that the antibodies that are produced will not only destroy the bacteria that they were produced for, but because of the close resemblance and the mimicry, then they end up destroying also the human tissue, and that is tissue injury, which will usually lead to an inflammatory response. Having looked at that, let us now look at how do these children present? What do we expect? And then how do we make a diagnosis? It's important to remember that no clinical or lab findings is pathognomonic for acute rheumatic fever. We don't have any pathognomonic signs. Pathognomonic means that if that sign is there, it is definitely that diagnosis. So we don't have that kind of scenario with acute rheumatic fever. Therefore, there's a gentleman called T. Duckett Jones who gave guidelines in the year 1944 that were to aid in making a diagnosis of acute rheumatic fever and also prevent overdiagnosing the same. So the T.D. Jones criteria is intended only for the diagnosis of the initial attack. So you only use the T.D. Jones criteria when you're making the first initial diagnosis of acute rheumatic fever. It is not used for recurrences because that's a patient who has already had the first attack, and so they may come up with recurrences. So we don't use the T.D. Jones criteria to make subsequent diagnosis in a child who has already been diagnosed initially with rheumatic fever. You only use the T.D. Jones criteria when you're making the initial first, the index diagnosis for rheumatic fever. In this respect, therefore, we have criteria that are categorized as major, and then we have certain criteria that are categorized as minor. So we have 5 major criteria, and then we have 4 minor criteria. Besides that, there has to be an absolute evidence of recent streptococcal throat infection. And how do you acquire that evidence? Is either by microbiologic studies or serologic studies. That means either the organism is cultured from specimens from the throat, obtained from the throat, and you're able to culture the organism, or you're able to demonstrate antibody titers against the streptococcal bacteria. So 5 major criteria, 4 minor criteria, and we shall see how the two relate with one another. In either case, there has to be an absolute evidence of recent group A streptococcal infection. And like we said, it can either by demonstrating the presence of the microorganism or demonstrating antibodies against it. Therefore, the diagnosis of acute rheumatic fever can be established by having two major signs or one major sign together with two minor signs, plus evidence of recent streptococcal pharyngitis. I'll say that again. In order to make a diagnosis of acute rheumatic fever, and remember we are making the index diagnosis, this is what you need. Of the major and minor criteria, you need at least two major criteria on their own, plus evidence of recent streptococcal pharyngitis. Or you can have one minor, but it must be accompanied by two major signs, and again with evidence of recent streptococcal pharyngitis. That is how we use the Jones criteria. However, we have some few exceptions to that criteria. The first one is in a situation where a child presents with chorea only. A child may not have all fit the criteria, as we have said, that it has to be two major and evidence of streptococcal infection, or one major, two minor and evidence of streptococcal infection. There are exemptions to that rule. And the first one I'm saying is chorea being the main manifestation. Any child who presents with acute rheumatic fever and the only sign they're having is chorea, which we shall see in a short while, this patient can be diagnosed as having acute rheumatic fever without following the Jones criteria in a very strict manner. These children, if a child presents with chorea, they must be evaluated for the presence of carditis. That means a child who presents with chorea only must be evaluated just to be sure that there isn't a coexisting carditis, and that is done by doing an echogram. The other scenario where you can make a diagnosis of rheumatic fever without adhering 100% to the Jones criteria is when a patient presents with indolent carditis. Indolent carditis means that the carditis has developed slowly over time, insidious in nature. And that happens to be the only manifestation the child may present with. And these children will usually present much, much later, several months after they have suffered the acute pharyngeal streptococcal pharyngitis. These children, again, a diagnosis of rheumatic fever can be made without strictly following the Jones criteria of two major with the streptococcal evidence, or one major, two minor and streptococcal evidence. So long as a patient presents with chorea alone, that patient can be diagnosed as having acute rheumatic fever. What else must be done for this child? They must be evaluated for any existing carditis. Number two is those children who come in with carditis, which is usually of slow onset, insidious in nature. They will usually come much, much later after the streptococcal throat infection. And again, these children must be continually checked for with echocardiography to rule out serious carditis. So, what are the major manifestations? They are 5 in nature, rather in number. And the presence of two major criteria, like we have already said, with evidence of recent streptococcal infection fulfills the Jones criteria, and therefore this kind of child should be diagnosed as having acute rheumatic fever. And you said, remember that for you to say you have evidence is either you have done serology for streptococcus bacteria, or you have cultured the organism. So the first major criteria we are going to discuss is polyarthritis. I want you to pay attention to this. It is migratory polyarthritis, not just arthritis. The word, as the word suggests, it's migratory, which means it keeps migrating. It will be moving from one joint to another, or from two joints to another joint, or from one joint to another two joints, like that. And then it is poly. So the fact that it affects more than one joint is the reason we call it polyarthritis. The fact that it keeps jumping from one joint to another then gives it the name migratory. So it is migratory polyarthritis. If you cannot establish that kind of history, then you cannot say there is migratory polyarthritis. This is a very important symptom to pick from the patient. Make sure you get it correct. So in this case, we are saying arthritis will usually occur, actually is the commonest occurrence among children who present with acute rheumatic fever. 75% of children who present with acute rheumatic fever will usually present with migratory polyarthritis. And another thing to remember, besides the fact that it is migratory in nature and that it affects more than one joint, the other thing to remember is it affects large joints. What are the large joints? We are talking about the knees, we are talking about the elbows, we are talking about the wrists, we are talking about the ankle joints, major or large joints. However, it doesn't commonly affect the hip joint. So take note of that. And because we are saying it affects large joints mainly, that means we are excluding the small joints. That is a very important thing for you to remember when it comes to differential diagnosis, because you do not want to overdiagnose rheumatic fever. And at the same time, you also don't want to underdiagnose. So I'm saying that the arthritis of rheumatic fever does not affect one joint. And if you remember from our very first statement of defining what is acute rheumatic fever, we said is non-suppurative inflammation. So the joints will not be containing pus. If a joint has pus, it is least likely that this child could be having rheumatic fever. Rather, you better be thinking about septic arthritis, which again has its own management criteria. So the arthritis of rheumatic fever affects more than one joint. It's never one joint. They're usually the large joints, the knees, the ankles, the wrists, and the elbows. While one joint may start getting inflamed for around 3 days, by the time it's getting better on its own. In fact, sometimes it doesn't need any treatment. It just resolves on its own. And by that time, another joint is taken up. It's like a relay. If you remember the relay run, it's like a relay. Okay? So involvement of the spine and small joints of the hands and feet or hip is uncommon. Like I said, it will be the commonest manifestation in children who present with rheumatic fever. And now we are saying it is usually the earliest manifestation of acute rheumatic fever. And it will usually correlate with the peak anti-streptococcal antibody titers. That is to say that when these children present with rheumatic fever, particularly the polyarthritis, at that time, the anti-streptococcal O titers are usually at the highest. They're usually at their peak. So if you do your antibody titers at that time, you are likely to get a positive result. The joints are generally hot, red, and swollen. Those are just signs of inflammation, and tender. And sometimes it is so disturbing that even when a child sleeps and the joints are touched by the blanket or the sheets, they become uncomfortable. It is that bad. And sometimes the pain that the child may be experiencing may not correlate very well with what you're finding as a clinician. That means the pain is so much compared to the signs of inflammation that can be observed. That is something that happens with these children when they present with polyarthritis. And like we said, the joint involvement is characteristically migratory in nature. That means, like I said before, 1 to 3 days, even with or without treatment, and usually it's like a relay. As the initial joint is getting better, another joint is beginning, or 2 more other joints are beginning to get inflamed. That is the nature of the polyarthritis in rheumatic fever. And it's a very important thing for you to pick so that you don't miss it. It's also important to remember that the arthritis may persist in its severe form for a couple of weeks, particularly in children who are not attended to or they are not treated. Please listen to this. If a child presents with a fever and arthritis is suspected, and this child is also suspected to have acute rheumatic fever, please do not give salicylates at that point because you're going to mask its diagnosis. If a child is presenting with what you're not so sure of, but it looks like migratory polyarthritis, but again, you're not so sure, the picture is not very clear, the advice or the recommendation is that do not give salicylates because you're going to mask it. What is rather recommended is that you give other analgesics like paracetamol, for example, like Brufen, for example. And these children, as you wait to see how the arthritis progresses. So what you do is at least relieve their pain and wait to see what happens. Like you can see in this box, there's usually a dramatic response to even small doses of salicylates. Okay? So, in case by whatever chance this child ends up taking salicylates and the response is as dramatic as this statement puts it, then that also helps in making the diagnosis. However, if a child takes salicylates and there is no response, and we are saying that the response of acute rheumatic fever, the arthritis of acute rheumatic fever to salicylates is fantastic. It means if you give a child salicylate and they do not respond, then you better be looking for an alternative diagnosis. It is most likely not rheumatic fever. But what I'm saying is, if you're not so sure, but you think it could be, withhold salicylates. Use alternative analgesia as you see how the joint picture progresses so that you can have a definitive diagnosis. However, in the event that salicylates are given and the improvement is dramatic, then that helps you to confirm. And number 3, if you give salicylates and nothing happens, they don't improve as quickly as we expect, then chances are it is not arthritis of rheumatic fever. The good thing is that the arthritis of rheumatic fever does not cause deformities. Let us now talk about carditis. And I will say at this point that carditis is actually the reason why acute rheumatic fever becomes very important, because the involvement of the heart is what leaves the serious rheumatic heart disease, and it is pretty debilitating in nature. Carditis is what makes rheumatic fever very, very important. Remember, you have already looked at arthritis. It is very dramatic, one joint following another or 3 joints following each other like that. And we have seen the pain is pretty intense, but it doesn't leave sequelae behind. But carditis can even be silent, but the consequences are far-reaching. So, carditis and the resulting chronic rheumatic heart disease are the most serious manifestations of acute rheumatic fever and account for essentially all of the associated morbidity and mortality. I think I have also emphasized this point right from the beginning of this lecture. So, rheumatic carditis is usually characterized by a pancarditis. That means that all the areas of the heart are affected. You will have the pericardium being affected. You'll have the myocardium being affected. And then you also have the endocardium being affected. And actually, the endocardium is the one that is affected the most. That is to say, as we shall see, that when the involvement is only of the myocardium, pericardium, and not the endocardium, it may not be rheumatic fever, because rheumatic fever, the commonest aspect of the heart that is affected will be the endocardium. So these children will either present with a very serious it's on a spectrum. So they can present with very severe carditis, which can even lead to death, heart failure, and even death, or they may just present with a mild transient cardiac involvement. So endocarditis will usually now mainly, the organ that is affected the most on the inner lining of the heart will be the valves. And usually when the valves are affected, what the patient will present with will be murmurs. Remember, a murmur is just a representation. You hear a murmur because of turbulent flow through the valve. The turbulent flow may be either because the valve is not able to open adequately, or it is not able to close adequately when it is supposed to close or open respectively. And so there will be turbulent flow, and that is what will help you, will cause you to hear the murmur. So murmurs is a universal finding in the rheumatic carditis, whereas the presence of pericarditis or myocarditis can vary. In most cases, the valve that is mostly affected will be the mitral valve, followed by aortic valve. Very rarely will you find the valves on the right heart being affected. That is the tricuspid and the pulmonary. The commonest valve to be affected will be the mitral valve, followed by the aortic valve. It can be only the mitral valve, but sometimes it can be both the mitral valve and aortic valve. And in each case, it can be stenosis, it can be regurgitation, or both. Like I said, myocarditis and pericarditis without evidence of endocarditis is rarely due to rheumatic fever. That is what we are saying. That of the pancarditis, the commonest layer will be the endocardium. And how will it manifest commonly? It will manifest by the valvular involvement. Either they will sclerose, become stenosed, or they will not be able to close well. They will regurgitate. The commonest valve to be affected is the mitral valve, followed by aortic. And it can be only the mitral valve involved or both the mitral valve and the aorta. So pay attention to the child who presents with myocarditis and pericarditis without the involvement of endocarditis. It may not be rheumatic fever or rheumatic heart disease. Like I already said, isolated aortic or right-sided valvular involvement is very rare, very uncommon. Commonest is mitral, then aortic, or both. But no, it doesn't skip mitral. Mitral is the first culprit. Serious and long-term illness is related entirely to valvular heart disease. You know, when we said in the beginning that rheumatic fever is important in our setting, it is because of what it leads to. Rheumatic fever, like I said, is a forerunner of rheumatic heart disease. Rheumatic heart disease is a valvular lesion disorder. When the valves cannot close adequately, when the valves cannot open adequately, there will be hemodynamic changes in the cardiac cycle. And when you learn about rheumatic heart disease and you will study each valve and the consequences of its stenosis or its regurgitation, then you'll understand this. That is why I said rheumatic heart disease is very debilitating. If we can prevent the occurrence of rheumatic fever, then that will be a very good thing to do. So serious and long-term illness is related entirely to valvular heart disease, which is because of an attack or recurrent attacks of acute rheumatic fever. With this statement, then, we know that once a child presents rheumatic fever, we want to prevent any further attacks in future. Because with every other attack of rheumatic fever, the chances of getting carditis, if the initial one was also involved with carditis, are very high. And the chances are it is likely to leave a more serious sequelae. Okay, so that if it was just one valve involved, now you may have more than one valve involved. And that also impacts on the hemodynamics in the cardiac cycle. So the major consequence of acute rheumatic carditis is chronic progressive valvular disease, particularly valvular stenosis, which can require valve replacement and can also predispose to infective endocarditis. So you can see it becomes like a cascade. It's like a myriad of things, from a throat infection that could be treated adequately, and then children will not develop rheumatic fever. If they develop a rheumatic fever and they also develop carditis, see what can happen. They will end up with rheumatic heart disease, a very debilitating heart condition. And in future, going forward, it means the only way they can continue living is by having their valves replaced by a prosthetic. Besides that, once the valves have been injured, the heart is now more predisposed to developing infective endocarditis again, which is a very serious manifestation because it will be one of the common causes why a child with a pre-existing heart condition will end up having heart failure, infective endocarditis. So children who will usually present with carditis in rheumatic fever will have tachycardia, and then they will also have a murmur. Remember, anytime there is valvular stenosis or regurgitation, there will be turbulent flow, and then there will be a murmur when you auscultate. Tachycardia is just a compensatory mechanism to try and enhance the cardiac pumping and supply of blood. So we have children who may be moderately ill, others are severely ill. It's a spectrum. And this can result in cardiomegaly, and sometimes other children may develop overt congestive heart failure. And when they have heart failure, then they are likely to have the tender hepatomegaly and also edema. Edema not only in the periphery, but also in the pulmonary vasculature or in the pulmonary circulation. Now, if a child presents with with carditis when they're having acute rheumatic fever, the way to confirm that is to do an echocardiography. And what the echo does, it will confirm to you or show you pericardial effusion. It will show decreased ventricular contractility, and also it will show the valvular damage of both the mitral and or the aortic valve. So what you need to do is an echo to confirm. What will you see? Pericardial effusion, decreased ventricular contractility, and the valvular damage, which valve it is and what kind of damage it is. So if a patient has mitral regurgitation, they will have a systolic murmur. And for you to know whether it is regurgitation or stenosis, first and primarily you need to understand the cardiac cycle so that you know when the heart is contracting, when the ventricles are contracting, how should the valves behave? Which valve should close and which one should open? And when it is diastole, the heart is relaxed and filling, which valves are supposed to open and which valves are supposed to close? It therefore means that if an intraventricular valve, that is the mitral or tricuspid, has stenosis, okay, what will happen? Stenosis will affect the ability of the valve to open. It means when the blood is filling, the heart is filling, it is supposed to pass through well-opened or patent valves. But when they are stenosed, then there will be turbulent flow during diastole, when the heart is filling. And so your murmur will be diastolic. So how do we interpret that? A diastolic murmur at the intraventricular valves will denote or suggest stenosis. Look at it when it is systole. During systole, the ventricles are contracting. What are we expecting? We expect that intraventricular valves should close. And so if you have a murmur which is occurring during systole, it means there is turbulent flow through the atrioventricular valves, that is either the mitral or the tricuspid valves, during systole. Those valves are supposed to close, which means they're not closing. It means they're regurgitating. So that becomes a systolic murmur. And that is why in this statement we are saying mitral regurgitation will present with a systolic murmur. When you remember your examination of the CVS, we know that the apex beat corresponds to the mitral valve. So if you pick a murmur at the apex beat, it is telling you about what is happening at the mitral valve. And then we have the other auscultatory centers of the heart, areas that you need to know. So the way we have interpreted the intraventricular valves, the opposite is the case with the aortic and pulmonary valves during systole and during diastole. So if you understand the cardiac cycle, what happens during which cycle, during systole and diastole, which valves are supposed to close, which ones are supposed to open, and so then you'll be able to interpret. So if there is a systolic murmur in this place, is it because the blood is regurgitating, or it is the flow is being obstructed? And then you make that kind of interpretation. Now, in patients who present with significant mitral valve damage, it may also be associated with the mid-diastolic murmur. Now, if there is a diastolic murmur, now you know there is both regurgitation and there is also stenosis. This valve is not able to close adequately during systole, and it is also not able to open adequately during diastole. So you have both a systolic and diastolic murmur, which we usually call continuous murmur. The aorta, on the other hand, when it is not functioning sufficiently, it means that there will be a diastolic, when there is a systolic murmur, no, let me go it this way. There will be a diastolic murmur at the aortic area when there is aortic insufficiency. And I'll keep repeating this. Please revise your cardiac cycle if you're able, so for you to be able to interpret the murmurs and then know, is it because of stenosis of that valve or is it because of regurgitation? The aortic auscultatory site is usually the left side, the second intercostal space. Okay. Please note that echocardiography that demonstrates valvular regurgitation without accompanying auscultatory evidence does not satisfy the Jones criteria. It means if clinically you cannot be able to pick the murmur with your stethoscope, but the echocardiography shows there is valvular regurgitation, this particular finding does not fit in the Jones criteria. Okay? That means that whatever is picked on the echo should corroborate with what is picked during examination. Let's now look at major sign number 3, that is chorea. The chorea that we see in acute rheumatic fever is referred to as Sydenham chorea. And this will usually present in up to 10 to 15% of children who present or who suffer from acute rheumatic fever. Usually, it can be presented as an isolated, frequently subtle muscle movement disorder. So, the patient will have very subtle muscle movement disorders that you may not notice very easily. So you need to know in order to see. So there will be the subtle disordered muscle movements. There will be emotional instability. The child will be uncoordinated. Their school performance is affected. Their movements are uncontrolled. And then they also have various facial expressions, grimacing. So the first thing, perhaps, if a child is presenting with chorea only, maybe the initial complaints will come from school that this child is not performing well. Remember, we said chorea. Chorea comes in, it's a very insidious. It can occur several months after the presentation of the throat infection. And so the child is emotional, that is, they're having mood instability, they're emotional all the time, they're not performing well in school, they're uncoordinated, they have these uncontrolled subtle muscle movements, which may be construed by the teachers to mean they're being cheeky, yet they're not. They have uncontrollable movements. They'll not be able to write well. They're making faces. And so this kind of child may actually be punished when they shouldn't. They're just sick. And you as a clinician, you must pay attention to these kinds of presentations and be able to put one and one together and know what is going on. So that is chorea. It affects 10 to 15% of the children who present with acute rheumatic fever, very subtle muscle movements, mood changes, and coordination, poor school performance, and grimacing. What is so specific about this presentation of chorea is that when the child is stressed, they become worse. And when the child is asleep, they also become less. So they are made worse by stress and relieved. You remember when you're describing a presentation, you talk about what are the aggravating factors and what are the relieving factors. In this case, this presentation is made worse by stress and it is lessened by sleep. So the latent period of acute group A streptococcal infection to chorea is usually longer than that for arthritis or carditis. So if we said carditis can occur slowly, how much more chorea? Chorea takes a longer time, like we already said. The onset can be insidious, and the symptoms will usually present several months before anybody ever notices that there is a problem. Because remember, we are saying they are very subtle and they can easily be misinterpreted in a different way. How would you be able to elicit chorea movements clinically? Number one, there will be the milkmaid's grip. The milkmaid's grip refers to irregular contractions and relaxations of the muscle of the fingers, that is of the patient's fingers, while squeezing the examiner's finger. So what you do, you will give them your finger for the child to hold and grip. When they grip, you will be able to sense irregular contractions and relaxations of the muscles of the patient. That is what we call milkmaid's grip. It's like they're trying to milk a cow. There's also spooning and pronation of the hands when the patient's arms are extended. So, besides offering them your finger for them to grip, you also ask them to extend their arms, their upper arms. And then you will see spooning and pronation movements. There is the Wormian darting movements of the tongue when you ask the patient to protrude. And that is something you need to see to know. And then examination of handwriting to evaluate fine motor movements. That again will be difficult because of the uncoordinated muscle contractions. These are some of the things you can examine for in order to establish the presence of chorea. I have selected for you a few videos that I found on YouTube, and they are very good. They can help you to understand how chorea looks like so that you can be able to recognize it when you see it. These links are in the description box. So you can go there and then watch, and you'll be able to understand how chorea really presents like. So the diagnosis is usually based on clinical findings and a supportive evidence of group A streptococcal antibodies. However, since we said that chorea can take a really long time before the clinical manifestations occur, sometimes that prolonged period may interfere with the concentration of the antibodies. And so by the time the child is presenting with chorea and you want to do the antibody titers for the streptococcus, you may not find it. Okay. Another good thing about chorea is while it is also very dramatic and the acute illness can be very distressing both to the child and to the caregivers, it rarely leads to permanent neurologic sequelae. So far, we have looked at 3 manifestation major criteria, and so far only one, carditis, is leaving serious consequences behind. Chorea doesn't, arthritis doesn't. Let us now look at erythema marginatum. These are the manifestations or the lesions we see on the skin. It occurs rarely, affecting only up to a third max, less than 3% of the children who will present with acute rheumatic fever. When it occurs, it is characterized by a rash, and that rash occurs on the trunk, okay, but does not affect the face. So, it is erythematous in nature. It's a macular rash, with a pale center. You may not be able to appreciate this very well in a patient who is dark-skinned, but it is very well appreciated in patients who are light-skinned. So remember, it's a rash, erythematous macular lesions with a pale center, and there is no pruritus. So the patient will not report itching. Another thing is the trunks and extremities are the ones which are affected. The face is spared. And usually, if the skin is warmed, then it's easier for you to see the erythema marginatum. So that is an image of what you would expect to see in a patient who has erythema marginatum. Not very common, but occurs. So you can see the margins and you can see the pale center. This is a child who is light-skinned, and so it is easy to see. Let's now talk about subcutaneous nodules. These ones again are rare, and they will usually consist of a firm nodule, usually about 1 centimeter in diameter, and they don't occur anywhere. They commonly occur on the extensor surfaces of tendons and near bony prominences. So, if you're looking for subcutaneous nodules, you're looking for them over the extensor surfaces, near tendons and bony prominences. They will be firm, they'll be non-tender, and then they will be about 1 centimeter in diameter. Like I said, it's rare. Less than 1% of children who present with rheumatic fever will present with subcutaneous nodules. It has also been found that there is a great correlation between the presence of these nodules and significant rheumatic heart disease. It means of the few that will get subcutaneous nodules, majority will end up with rheumatic heart disease. So while it is rare, its presence denotes a not so good outcome. And that is how subcutaneous nodules look like. You can see it here. And you can also see here. Having looked at the 5 major criteria, we have looked at the arthritis and explained how it migrates and how it affects many joints, how it is very painful compared to other signs of inflammation. And we have talked about the do's and the don'ts when you suspect acute rheumatic fever and the arthritis is not very clear. We've talked about carditis and its importance. So far, you've seen of the major criteria, the 5 of them, it is the only one leaving behind serious consequences or sequelae. We've talked about erythema marginatum. We've talked about subcutaneous nodules, and also we've talked about chorea. And again, chorea, while it may look very dramatic, thankfully it does not leave serious sequelae. Now, let us look at the minor manifestations. We said there are 4 of them. Number 1 is arthralgia. This is the presence of joint pains which does not fit the migratory polyarthritic nature of the major sign. So the child may have joint pains or discomfort, but it doesn't quite fit the description of migratory polyarthritis. When that happens, it becomes a minor sign. When it is the typical migratory polyarthritis, it is a major sign. When there's joint pain and discomfort, but it doesn't meet the criteria for migratory polyarthritis, it becomes arthralgia and falls under minor criteria. That is number 1. Number 2 is fever. And fever will usually be present, especially in the early course of the illness. Number 3, we have elevated markers of inflammation, acute phase reactants. So you will usually need to do an ESR or C-reactive proteins. These are just markers of inflammation and they will usually be raised. That is number 3. And then number 4, we have a prolonged PR interval on ECG. These are the 4 minor criteria. So like remember we said, if a patient does not present with the 2 majors and evidence of streptococcal infection, they may have 1 major, but they must have 2 minors and evidence of streptococcal infection for you to be able to make a diagnosis of acute rheumatic fever. So 2 clinical signs, 1 laboratory, 1 imaging. Laboratory gives you 2 options, erythrocyte sedimentation rate, which will be raised, or C-reactive proteins. These are acute phase markers of inflammation. Fever will be early in the disease. Arthralgia, when the joint discomfort does not fit the migratory polyarthritis that we've already discussed, and the prolonged PR interval on ECG. Of this history, a third who will not give you a history of that they can remember they had a throat infection or they even had a treatment for it. Because if they can't remember, it means it just passed by. And you only do anti-streptococcal or titers, you will only get a positive result into up to 85% of patients. You still have 15% that may have acute rheumatic fever, but you do not have an absolute evidence for streptococcal pharyngitis. So what do? Evidence has also shown that when 3 different types of antibodies are measured, then you have a higher chance of being able to demonstrate recent streptococcal infection. Then you have 95 to 100% elevation. So what do? You do anti-streptococcal or anti-streptolysin O, you do anti-DNase B, and then you also do it's a mouth-filling word, man. You do that. So this one will give you a positive rate of up to 95 to 100%, which is a better thing to do. Therefore, we are saying when you want to demonstrate or document evidence of group A streptococcal infection, you're better off asking for these 3 antibody titers together than just the ASOT. Anti-streptococcal O titer is abbreviated as ASOT. So in acute rheumatic fever, when you suspect it, do the multiple antibody test. it will give you better result outcome. So let us look at the summary for making a diagnosis of rheumatic fever. We have the major signs, remember, and we also have the minor signs. Of the major signs, remember the migratory polyarthritis and its behavior and its nature, carditis, the murmurs, the tachycardia, the cardiomegaly plus or minus heart failure, chorea, which is the Sydenham chorea, the uncoordinated movements, the mood changes, the poor performance in school, and so on and so forth. Erythema marginatum, which is a macular rash with a pale center, very easy to see in light-skinned people compared to dark-skinned children, and its appearance is made better when the skin is warmed. And then we have the subcutaneous nodules, which occurs in a very small percentage of patients, occurring on bony prominences, nodular tissue, about 1 centimeter in diameter. And remember, we said its presence should give you an index of suspicion for carditis. Then we have the minor signs, which were 4. 2 were clinical, 1 laboratory, and 1 imaging. Arthralgia, that is in the absence of the typical migratory polyarthritis. We have fever early in the course of illness. We have the acute phase reactants or inflammatory markers, and raised ESR or raised C-reactive proteins. And number 3, we have imaging, which shows prolonged PR interval on ECG. Therefore, like we already said, diagnosis is made by the presence of 2 major signs or 1 major sign and 2 minors, and in both cases, there should be supporting evidence of recent streptococcal pharyngitis, which we have just talked about less than a minute ago, that it is better to do the 3 antibody titers rather than only 1 for better outcomes. Assort only will be positive in up to 85% of patients, but when you do the 3, then you have a higher chance of isolating or having the evidence for streptococcal infection. Why? We don't want to underdiagnose and we do not want to overdiagnose. So, there's this statement that the diagnosis of acute rheumatic fever should not be made in patients with increasing streptococcal antibody titers who do not fulfill the Jones criteria. That is because such titer changes may just be coincidental. That is to say, if a child has had streptococcal pharyngitis, the antibody titers are high, fine. But if they do not have the multisystemic manifestation that we've seen, it doesn't make them have rheumatic fever. You cannot say they have rheumatic fever because of that, okay? So rising antibody titers must occur together with the other signs that we have talked about in order for you to make a diagnosis of acute rheumatic fever. What are some of the differential diagnoses? The first one is rheumatoid arthritis. And like we said, with rheumatoid arthritis, now there's the epidemiologic picture for acute rheumatic fever. It's common in the school-going age. But rheumatoid arthritis will be usually present in very younger children. Okay? The joint pain is not as much as the joint pain of acute rheumatic fever. Okay? And then spiking fevers, lymphadenopathy, splenomegaly will usually suggest rheumatic arthritis or rheumatoid arthritis rather than acute rheumatic fever. Remember, in acute rheumatic fever, we did not talk about spiking fevers. We only said that the fever will be present especially at the onset of illness. We did not see any lymphadenopathy. We did not see any splenomegaly. Okay? So when you see these, and then of course the joints involved are smaller, and then the child is younger, it will highly suggest rheumatoid arthritis. And like we said, children with acute rheumatic fever presenting with arthritis will respond dramatically to salicylates. And so if you're not so sure and you give your salicylates, if they have rheumatoid arthritis, the response will not be as dramatic as what you see in acute rheumatic fever. And that's how you differentiate it. The other differential diagnosis to consider is SLE, systemic lupus erythematosus. For systemic lupus erythematosus, you differentiate it from acute rheumatic fever on the basis of the presence of anti-nuclear antibodies, which are present in SLE, but they are not present in acute rheumatic fever. Also, other causes of arthritis need to be ruled out. Serum sickness, malignancies, gonococcal arthritis. All other known causes of arthritis should be ruled out if you're not sure. All right? Now, when carditis is the main or the sole major manifestation of suspected acute rheumatic fever, then as a clinician, you need to rule out other causes of myocarditis or carditis. They could be viral, causing myocarditis or pericarditis. It could be Kawasaki disease, which is very common in our setup. It could be infective endocarditis. Now, remember, when we're talking about differential diagnosis, it is usually the answer to this question, what else could it be? And so even as we have talked about rheumatoid arthritis, systemic lupus erythematosus, and now we are talking about carditis by itself, we are asking ourselves, what else could it be? And the answer comes because of how else the patient is presenting. When they have overlapping features, when a patient has an overlapping feature, then you develop a differential diagnosis. The only way to make sure the differential is present or absent is to do an investigation. So all these differentials we are mentioning, they are not stereotype. They will depend on how else the patient is presenting. So in this case, we are saying when carditis is the only manifestation of rheumatic fever, which we have already seen could be the case, then the other causes of carditis or pancarditis should be ruled out. Patients with infective endocarditis can also have joint pains. And it is because of this that then we are considering it as a differential. Now, the distinguishing factor for endocarditis, that is infective endocarditis, will be the blood culture. Blood cultures in endocarditis will be suggestive of a hematogenous microorganism. Okay? Also, in patients who present with infective endocarditis, they will have other accompanying features. They may have hematuria, they will have splenomegaly and splinter hemorrhages. These manifestations were not present. We did not see them when we are looking at either the major criteria or the minor criteria. When you see accompanying symptoms like this, then you need to think outside the box and therefore rule out any other coexisting morbidity. Let's talk about treatment. You have already made your diagnosis of acute rheumatic fever. Now it's time to treat the patient. The first thing is to put them on bed rest. We all know, as you already know, is that when a patient is inflamed or when a tissue organ is inflamed, rest is a good recommendation. So these children are in an inflammatory state, so they need to be put on bed rest and monitored closely for evidence of carditis in case they did not present with it initially. Remember, we said majority of the children will present with arthritis. So even if they present with arthritis or chorea, they must be evaluated or monitored closely for possibility of developing carditis. However, these children can be allowed to ambulate as soon as the signs of acute inflammation have subsided. It is important to remember that patients who present with carditis will usually require longer periods of bed rest. And it is even longer when they have heart failure. Now let's talk about antibiotic therapy. Remember that a patient has acute rheumatic fever, there is a preceding streptococcal throat infection. This infection may or may not still be lingering. Remember the small percentage of patients in whom you can find a positive culture, the others you will not find. So the point is this: the streptococcus may or may not be there. So you don't want to take chances. All children who present with acute rheumatic fever need to be put on an initial course of antibiotics of up to 10 days. Whether or not the culture results for the throat swab are positive, the child needs to be put on a 10 days course of oral antibiotic. And you are free to choose. You can use any penicillin. If the child is hypersensitive to penicillin, then you can use erythromycin. If it is not possible to use these ones, then you can give a single dose of IM benzathine penicillin to the patient. So you have a choice of two. Give oral antibiotics for 10 days, preferably a penicillin. If for whatever reason you're not able to give a penicillin or is not indicated, then the other option is erythromycin. The other second choice you have is to give a single dose of IM injection benzathine penicillin. This helps to eradicate any streptococcus that may still be lingering around. After this initial treatment targeting the streptococcus, then the child needs to be put on antibiotic therapy for prophylaxis. That is the long-term prophylaxis. And then we shall see a little bit later on how do we give the long-term prophylaxis. So antibiotics are given in two scenarios. One, the first is at the time of the initial diagnosis, when you must give your antibiotics to make sure that you're eliminating any lingering streptococcus. And then after that, the patient needs to have the prophylaxis, and we shall see for how long do you give and what can you use. Let's talk about anti-inflammatory therapy. Here we have two choices. For controlling the inflammation, you can use salicylates, which are very effective, or you can use corticosteroids. And we shall see in which cases you use which one. But we have said that salicylates and corticosteroids should not be given when you're just suspecting arthralgia. When you're just suspecting arthralgia, withhold salicylates and use alternative analgesia as you watch the progression and the behavior of the arthritis, if it meets the criteria for rheumatic fever. This is because when you give salicylates prematurely, then you're going to mask the real migratory polyarthritis, and then you will not be able to make a concrete diagnosis. So long as you're able to control the pain, as you're observing the nature of the arthritis and how it is behaving, that is sufficient. And then once you are sure, you can now put the child on salicylates. So this is what I'm saying, that other options can be used in order to control the pain. So those patients who present chiefly with migratory polyarthritis, but they do not have, but they have carditis. Okay, so we have this group of patients. They are presenting with migratory polyarthritis, which is the commonest manifestation, and then they also have carditis. However, they do not have cardiomegaly and they do not have heart failure. They only have maybe a murmur, they have tachycardia, but they don't have evidence for cardiomegaly, their apex is not displaced, and they do not have signs of heart failure. These children only need to be started on oral salicylates. Please, if a child only has migratory polyarthritis alone, or they have carditis without cardiomegaly, without heart failure, these are children, you only put them on salicylates. The dose is oral aspirin, 50 to 70 milligrams per kg per day, divided in 4 equal doses. You give it for 3 days. After the 3 days, you lower the dose to 50 milligrams, again per kg per day, again divided into 4 equal doses, and this goes on for 3 weeks. So you start with a high dose of up to 70 milligrams per kg per day in 4 divided doses, 3 days, and then you step down to 50 milligrams per kg per day. That goes on for 3 weeks. Remember, these are for children who present with arthritis only or carditis. They could be two, but as far as carditis is concerned, there is no cardiomegaly and there is no heart failure. So we have the second category of children who will usually have presented with carditis. Now, this carditis does not occur like the previous carditis we've talked about. This one, they will have tachycardia, they will have a murmur. Additionally, they will have cardiomegaly, or they'll also have heart failure. Remember, previously, the children who presented with carditis and or arthritis, we only gave them salicylates. In this case, when the carditis is accompanied with cardiomegaly and also is accompanied with congestive heart failure, now we do not go for salicylates, we go for corticosteroids. The steroid of choice is oral prednisolone, and the dose is 2 milligrams per kg per day in 4 divided doses for 2 to 3 weeks. After that, you halve the dose. That means you give them at 1 milligram per kg per day, again in divided doses, and you give that for a further 2 to 3 weeks. So the total steroid therapy duration will be maximum of 6 weeks, minimum of 4. What follows then? You don't just stop steroids like that. When you decide you have already done the correct duration, the child is improving well, then you start tapering off the steroid. And how do you do that? You reduce the steroid dosage by 5 milligrams per day. That means if the child was getting 80 milligrams, for instance, and now you have decided you want to start tapering it down, so you will give them a dose 5 milligrams less of the total daily dosing. And you do that tapering off every 2 to 3 days, not a daily affair. So when you taper it, you reduce the total dose by 5 milligrams today, you'll give it today, tomorrow, and then review on day 3. That's when you can consider tapering it further down until you are at 0. Now, when you begin tapering off the steroid, you introduce aspirin. The aspirin you introduce is at the lower dose of 50 milligrams per kg per day, just like we did in the child who presented with arthritis and carditis without cardiomegaly and heart failure. So, the moment you start tapering prednisolone down, you must now start introducing aspirin at the dose of 50 milligrams per kg per day in 4 divided doses, and this goes on for 6 weeks. Depending on how else the patient is presenting, then you may have to give them more treatment. For example, if they also have signs of heart failure, that means you're going to put them on digoxin, you're going to restrict their fluid and salt intake, you're going to put them on diuretics and also on oxygen. So it depends on how else the patient is presenting, all right? Then you give any further treatment. But of importance is to understand that children who present with carditis plus cardiomegaly and heart failure should be started on steroids. The steroid of choice is prednisolone, 2 milligrams per kg per day in divided doses. You give that for 2 to 3 weeks, and then you reduce the dose to 1 milligrams per kg per day, another 2 to 3 weeks, and then you start tapering off the steroid slowly. At the time when you start tapering off the steroid slowly, and we said it's a rate of 5 milligrams less per day of the total daily dose, then you start them on aspirin at 50 milligrams per kg per day, and that goes on for 6 weeks. Remember the other therapies in case they have heart failure. So, termination of the anti-inflammatory therapy may be followed by a reappearance of clinical manifestations or the laboratory abnormalities. In that kind of scenario, then treatment should be reinstated. Okay? If a child relapses or gets a recurrence of the symptoms or abnormal laboratory findings, then this child's treatment, anti-inflammatory treatment, should be restored. Let's talk about the chorea. Sometimes, like we said, chorea may occur as an isolated entity after the resolution of the pharyngitis. In this case, anti-inflammatories are not used in chorea. Instead, we use sedatives. And the sedative of choice, just like in convulsions of neonates, is oral phenobarbital. The dose is 16 to 32 milligrams, 6 to 8 hourly. If phenobarbital is not effective or is not available, then you can give oral haloperidol at the dose of 0.1 to 0.3 milligrams per kg per day, divided into 2 equal doses, or you can use oral chlorpromazine 0.5 milligrams per kg per day, 4 to 6 hourly. So if a child presents with chorea, these are not children for anti-inflammatories, no steroids needed, no aspirin needed. What they need is sedation. The drug of choice is phenobarbital, as we have seen. So now, let's talk about the complications. Arthritis and chorea of acute rheumatic fever will usually resolve completely without any sequelae. I think I've already mentioned that. Therefore, the long-term sequelae, like we said, of rheumatic fever are limited to the heart. And remember, I told you what makes rheumatic fever very important is the sequelae, the heart involvement. Chorea does not leave any damages. Arthritis does not leave any deformities. But the involvement of the heart muscle is what leads to complications, and it is why we must prevent this disease. So those patients who present with valvular disease secondary to acute rheumatic fever are usually at an increased risk of developing infective endocarditis. So infective endocarditis becomes a complication. This can occur anytime there is bacteremia from whatever cause. The commonest source of bacteria that cause endocarditis are those that are found in the oral cavity. Especially when the children are brushing their teeth very vigorously, they can injure their gums with the brush, and then the normal flora in the mouth gains access into the bloodstream and is what causes the endocarditis. So, the antibiotic regimes that are used to prevent recurrences of rheumatic fever have not been found to be adequate for prevention of infective endocarditis. So we must use another strategy. The benzathine penicillin that we shall talk about is not effective against infective endocarditis. Therefore, these patients require short-term antibiotic prophylaxis before they undergo any surgical procedure. before they undergo any dental procedure, anything that may cause bleeding and access of microorganisms into the bloodstream, these children need to have short-term antibiotic prophylaxis before any surgical procedure in order to prevent infective endocarditis. So the current recommendations regarding infective endocarditis should be followed. It is very important that when you are giving health education to these children when they have infective endocarditis, we also educate the parents and let them know the importance of good dental hygiene. Because like I told you, the commonest microorganisms that end up causing infective endocarditis in children with rheumatic heart disease come from the mouth. And so oral hygiene becomes very, very important. Now, in patients who have had rheumatic fever, but they have not had any evidence of residual valvular disease, you do not need to give them prophylaxis for endocarditis. So we are saying endocarditis, infective endocarditis is not only a worry or a concern when there has been residual valvular damage. A patient who has had carditis without any damage to the valves does not need prophylaxis for infective endocarditis. However, those who have rheumatic heart disease following rheumatic fever must have prophylaxis for infective endocarditis anytime they undergo any surgical or dental procedure. Now, let us look at the prognosis. The prognosis of these patients depends on three things. One, the clinical manifestation present at the time of the initial episode, that's very important. How the patient presents, which major signs they present with, really is important when you are talking or considering the prognosis. It also depends on the severity of the initial episode and also depends on their presence of recurrences. Three things determine the outcome or the end prognosis of rheumatic fever: the initial presentation, the severity at the time of the initial presentation, and whether or not there are recurrences. Because with every recurrence, especially if they had carditis, they may have an additional damage to the valves and the endocardium. So, group number one of patients, the category number one is patients with carditis. About 70% of patients who present with carditis with their initial episode of rheumatic fever will usually recover without any other residual negative effect to the heart. 70% will recover fully. Okay? The more severe, however, the more severe the initial cardiac involvement, the greater the risk of residual disease. That means that the more severe the carditis, the higher the chances that this child is likely to end up with rheumatic heart disease. But those who have mild carditis, 70% of them have been found to recover pretty well and entirely. The second category of patients are patients who have had carditis with the initial episode and have had recurrences which also involve presence of carditis. In these kinds of children, the risk of permanent heart damage is highly increased. That means the more recurrences that occur, the higher the risk of permanent heart damage, especially to the valves. So we have a third category of patients. These are patients who do not present with carditis with their initial episode of rheumatic fever. These patients, even if they have a recurrence, are also unlikely to develop carditis. That is what has been observed. Then we have a fourth category of patients. We say that patients who have had rheumatic fever are usually susceptible to recurrence any other time they get a reinfection of the upper respiratory tract with the streptococcus, group A streptococcus. So that means the development of rheumatic fever and the recurrence of another throat infection only makes it worse and makes it easier for the child to have another attack of rheumatic fever. Therefore, any child who has had rheumatic fever needs to have long-term continuous chemoprophylaxis, because we are saying that so long as a child has had acute rheumatic fever, in future, if they get another throat infection with streptococcus, the chances of them having another episode of rheumatic fever are also high. And remember, we do not want recurrences, because with every recurrence, the chance of damaging the heart further is also increased. That is the reason why these children should be on long-term continuous chemoprophylaxis. The fifth category of patients, we are saying that about 20% of patients who present with pure chorea and are not put on secondary prophylaxis develop rheumatic heart disease within 20 years. That means, remember we said that chorea may be the only presentation, in which case, again, it forms an exception to the Jones criteria, where we said that if a patient presents with chorea, you may not need all the two measures with the whatever, but you at least need evidence of streptococcal infection. And then we said a child who presents with chorea must be closely monitored for any evidence of developing carditis. And now we are saying that 20% of the children who present with chorea only are likely to develop carditis or rheumatic heart disease within 20 years going forward. Therefore, patients with chorea, even in the absence of other manifestations of rheumatic fever, will also require long-term antibiotic prophylaxis. So we have two categories of patients who require long-term antibiotic prophylaxis. Those who present with carditis and valvular damage, and then those who have presented with chorea. These two categories, so far we have seen, need lifelong prophylaxis. So, having said that, then, how do we prevent rheumatic fever and rheumatic heart disease? This is twofold. Number one, we need to control the group A streptococcal infection of the pharynx. Okay? We're saying prevention of both the initial and recurrent episodes depends on controlling group A streptococcal infections of the upper respiratory tract. Because remember, we have been able to demonstrate a link between the streptococcal URTI and the development of rheumatic fever when we began the lesson. And therefore, it means to prevent rheumatic fever, first and foremost, we need to control the group A streptococcal upper respiratory tract infection. Therefore, prevention of initial attacks, which we also refer to as primary prevention, will usually depend on identification and eradication of the streptococcal pharyngitis. That means as a clinician, you must be on the lookout. The children who come to you with throat infections, you need to check them out well, know whether it's viral or bacterial, and put them on antibiotics appropriately in order to prevent the possibility of developing rheumatic fever. So, individuals who have already suffered an attack of acute rheumatic fever are partially susceptible to recurrences of rheumatic fever. See, a child, like I said before, who has had an attack of rheumatic fever, and then they suffer another streptococcal throat infection, this child is likely to develop another attack of acute rheumatic fever. And it doesn't matter whether or not they show us symptoms. Therefore, what do we do with these patients? They must receive continuous prophylaxis. And that is what we refer to as secondary prevention. So the first prevention was in controlling the streptococcal URTI. The secondary prevention is controlling recurrences from future streptococcal pharyngitis by making sure that the child is on lifelong antibiotic prophylaxis. That is referred to as secondary prevention. So let's talk further on primary prevention. Here it is just about appropriate antibiotic therapy within 9 days of the onset of the throat infection. So a child should not have a throat infection for a very long time. Within 9 days, they should come to hospital or be identified and the throat infection promptly treated with antibiotics to which Streptococcus is sensitive. This strategy is highly effective in controlling rheumatic fever episodes. If we can be able to get these children with throat infection and treat them appropriately and adequately, we will by a great extent reduce the attacks of acute rheumatic fever. And you are talking about the initial attack, because it is the initial attack which even predisposes a child to another and another attack when they have another pharyngeal infection. So that is what we need to do. There is a statement here that about a third of patients with acute rheumatic fever do not recall a preceding episode of pharyngitis, and they did not seek therapy. So you can see. This means that we need to step up our education to parents, caregivers. It is not uncommon to find a mother just going over the counter to get a painkiller for the child because they had painful swallowing. It could have been better if they are seen and the infection is checked out if it is bacterial throat infection, possibly streptococcal in nature, and antibiotics are instituted accordingly. So we are saying that in up to a third of patients, there's about 30% of patients, they will not recall any episode of having had a throat infection. Let's talk about secondary prevention. This is for the children who have already suffered the first attack of rheumatic fever. So in secondary prevention, we want to prevent group A streptococcal pharyngitis in these patients, because it is the group A streptococcal pharyngitis that will lead to a recurrence of the acute rheumatic fever. And so that is the target. This kind of prevention requires daily antibiotic prophylaxis, and this should start as soon as the diagnosis is made, and it continues, as we shall see, the duration depending on how the patient has presented. So remember we said any child who comes in with rheumatic fever, while we start them on anti-inflammatory medication, we also straight away start them on a course of antibiotics. If it is oral, 10 days, or you can give the initial single dose of benzathine penicillin. That is the initial one to eliminate the streptococcus. These children now have already suffered rheumatic fever. They need to be protected from further recurrences of streptococcal throat infection, because the more they get these infections, the more they are likely to have recurrences of rheumatic fever. And if that rheumatic fever is associated with carditis, they have the chances of getting valvular damage. So these children need to be put on lifelong, not necessarily lifelong, but daily antibiotic prophylaxis. So the first category that we are going to consider are the children who have suffered carditis with the initial episode of rheumatic fever. Remember we said the commonest is arthritis and carditis. So carditis, in the first episode, these children should receive antibiotic prophylaxis way through their life until they become adults. This is because they are at a higher risk of having carditis with recurrences and of sustaining additional cardiac damage. Like I've already said, that anytime a child will have a recurring throat infection and they had carditis, there is a likelihood that they will get another rheumatic fever attack, and then they'll have further damage to the heart. That is what you're preventing. The second category of patients is those patients who did not have carditis with their initial episode of rheumatic fever. These patients are usually at a much lower risk of carditis, even if they get recurrences. And so, for these children who did not have carditis with their initial rheumatic fever episode, antibiotic prophylaxis will be started, but it will be discontinued when these children get into their early 20s, or it will be discontinued after 5 years, whichever is longer. That means if they are near 20 years, then you'll do 5 years prophylaxis. If they are maybe 10 years by the time they have their first acute rheumatic fever without carditis, then you'll give them their prophylaxis until they're in their 20s. Then you consider stopping, whichever is longer. So, the antibiotic regime of choice is benzathine penicillin administered intramuscularly. The dose is 1.2 mega units every 4 weeks. We use 4 weeks, not every month. We count the weeks. So you will give them IM benzathine penicillin G 1.2 mega units every 4 units. However, there are a few exceptions to this regime. Those children who are particularly at very high risk of contracting streptococcal infection, of course, this will be informed by the epidemiological information. If a child is living in a place where the prevalence of streptococcal throat infections is very high, they are the children you may not want to wait for until 4 weeks are over, but you may be giving them their benzathine penicillin every 3 weeks instead of 4 weeks. That is because in the last week of the 4 weeks, usually the amount or the concentration of the benzathine penicillin is very minimal and it may not offer adequate protection. Patients who can be able to comply and take medication orally don't have to be put on the painful benzathine penicillin. They can be given prophylaxis using oral penicillin V. The dose is 250 milligrams twice a day. Alternatively, they can be given sulfadiazine or sulfadoxazole. The dose is 500 milligrams for those children who are below 27 kilos and 1 gram for those children who are more than 27 kilograms, and it is a daily dosing. Penicillin is 250 milligrams twice a day. The sulfadiazine or sulfadoxazole is 500 milligrams for those who are less than 27 kilos and 1 gram for those who are more than 27 kilos, given as a single daily dose. If you have a patient who is allergic to penicillins or sulfonamides, then your other option is erythromycin, and erythromycin is given twice daily. Now, these oral regimes are only for patients who can comply and be able to take the medication daily. Otherwise, then they should just come every 4 weeks for the injection, and if they're in high risk in geographic area, they come every 3 weeks. So let's look at the summary of the duration of prophylaxis. So on one side, on the left, we shall have the category, and on the right, we shall have the duration. So if a patient presents with rheumatic fever without carditis with the initial episode, then you give them prophylaxis for 5 years or until they are 21 years of age, whichever is longer, like I said. If a patient has rheumatic fever with carditis but did not have any residual valvular damage, then these are children you'll give prophylaxis for 10 years or until they're 21 years of age, whichever of the two is longer. So the children who present without carditis with the initial episode, prophylaxis is for 5 years or until they're 21, whichever is longer of the two. if they had rheumatic fever with the first episode and carditis also, but did not have residual valvular damage, then the prophylaxis is 10 years or until they're 21 years, whichever of the two will be longer. Then we have the children who present with rheumatic fever, and in their initial episode, they ended up with residual valvular damage. These kinds of children should have their prophylaxis for 10 years or until they're 40 years of age, whichever of the two is longer. And sometimes some of these patients may be on prophylaxis for life. So this is a summary of how you make a decision on how do you give or for how long do you give the prophylaxis depending on the initial manifestation when they first present with rheumatic fever. Remember we said that acute rheumatic fever occurs as a delayed sequelae of streptococcal throat infection or pharyngitis. And that means that it's very important that if this infection is there or present in a child or an adolescent, it is treated promptly. So I prepared these slides for that particular reason. How to treat streptococcal pharyngitis. When you treat streptococcal pharyngitis effectively, then you also effectively prevent the development of rheumatic fever and subsequently or consequently development of rheumatic heart disease. Penicillins are the drugs of choice or the preferred antibiotics. We have Pen V. A child who is less than 27 kilos gets 250 milligrams 2 to 3 times daily for 10 days. If they're more than 27 kilos, you give them 500 milligrams 2 to 3 times daily. The duration in both cases is 10 days. The other penicillin that you can give is amoxicillin. For these ones, you give them 50 milligrams per kg per day for 10 days. This may be administered once daily or in 2 equal divided doses. So the daily dose is 50 milligrams per kg per day. Duration is 10 days, whether Pen V, whether amoxicillin. Just check the dosing against the weight of the child. In patients who may have allergies to penicillin, then you can use cephalosporins. And we have different generations. We have the first generation, cefalexin is a choice. You can give cefalexin. Again, the duration is 10 days at that dosage. You can give cefuroxime, which is a second generation cephalosporin, 10 milligrams per kg orally twice daily. Again, duration is 10 days. Do not exceed 250 milligrams per dose for cefuroxime. Do not exceed 5 milligrams per dose for cefalexin. And then we have cefpodoxin, which is a third generation oral antibiotic. The dose is 5 milligrams per kg per dose orally given BD. Please do not exceed 100 milligrams per dose. Again, this is given for 5 to 10 days. So this is the only antibiotic so far we are mentioning and bringing in 5 days. The others are 10 days. Then we have cefdina, which is also a third generation anti-cephalosporin, and the doses is as written. And then again, you can give 5 to 10 days. Please do not exceed 600 milligrams. Then we have macrolides. Macrolides will be what you are able to use if a patient is allergic to penicillin. So you give them azithromycin, 12 milligrams per kg per day for 5 days. You can also give clarithromycin at that dosage, and it is 10 days. 7.5 milligrams per kg per dose orally twice daily for 10 days. Then we have the lincosamides. This is the alternative you have if you cannot use macrolides, maybe because of resistance or whatever other reason, and you can also not use penicillins or cephalosporins. Clindamycin is a choice, 7 milligrams per kg per dose. Do not exceed 300 milligrams per dose It is given orally 3 times a day, and again, duration is 10 days. With that, we have come to the end of our lesson. You now know the importance of rheumatic fever. The importance mainly is the involvement of the heart. We have seen how to recognize it, how to make a diagnosis, how to examine the patients, how to give the anti-inflammatories, the antibiotics, how to give prophylaxis, and most importantly, we have looked at how to treat streptococcal pharyngitis effectively in order to prevent development of acute rheumatic fever. Please subscribe to the channel so that any other time I post something that may be of interest to you, maybe for your learning or for your revision, you can be able to know in good time. Please share and like with your friends. If you found this lesson valuable, if you found it informative, please share and like and with your friends. Our reference materials were the Nelson Textbook of Pediatrics and also the up-to-date site where we looked at the impact of dosing frequency on the efficiency of 10-day penicillin or amoxicillin therapy for streptococcal tonsillopharyngitis. These have been our main reference materials. I want to thank you so much for your attention. Thank you for checking in, and we hope to interact more. Thank you and have a lovely day. Bye.